Can I ask everybody to take a seat and we can start this session? Thank you very much. Thank you very much for showing up in such large numbers immediately after lunch in a session about a very hot topic, AI and its role in healthcare innovation. And in particular, we will look at AI and ethics. My name is Paul Timmers. I'm the moderator for the session of this afternoon. We've got 1.5 hours and we will start looking into various aspects of AI, how it works, what it brings, and in particular, the ethical aspects of that. I think everybody here is convinced or nearly convinced that AI is going to be important or is already important for healthcare innovation. Otherwise, you wouldn't be here. While AI is developing, policymakers across the world are reflecting on it and even under some pressure to address the ethical challenges that come with these new technologies, AI, artificial intelligence. For example, the European Commission, we happen to be here in Europe, and European Commission is certainly for policy making a reference point, had put in place a high-level group that developed guidelines for trustworthy AI, for AI and ethics. These guidelines have been issued in April this year, and a major European innovation initiative about which you will hear more, the European Institute of Technology, the health part of that, EIT Health, has decided to pilot and try out these guidelines amongst health innovators and startups. And the results of that pilot, the results of that survey, you are going to be the first one this afternoon who will actually hear about it. So we've got something new that you will get here this afternoon too. It's about responsible health innovation, but what exactly is that? And what can we learn also from experiences of the past, and where do we see things developing in terms of responsible AI and ethics, in particular when we are talking about health innovation. So we have a panel this afternoon that includes policymakers, academics, people from business, innovators in the field of health, and we aim for a constructive dialogue that adds something to the debate. And it would be very nice if you can also be part of that debate. So the intention is to do the following. We will get 2 case presentations, first to give some kind of practice feeling to what is happening around AI and ethics in health innovation. And after these case presentations, we'll get the panel who give their views on it, and then I will pose them some questions, and it would be nice if at that moment in time I can interact with you. So if you then also have questions, raise your hand and we will try to throw a microphone to you. Without further ado, let's get started in presenting 2 small cases of health innovation. And the first case will be from a company called AppTrace, and it will be presented by Umar Naim Ahmad. Umar, you've got the floor here. He's an anesthetic trainee, global health physician, has been working in international health policy and also, for example, algorithmic approaches to Ebola, to dealing with the Ebola epidemic. And now having a venture using artificial intelligence to understand, monitor, and improve the use of antibiotics. Umar, you have 5 minutes, okay?
Great.
Go ahead.
Excellent, that works. Thank you for having us here. My name is Umar Naim Ahmed. I'm the CEO of a company called AppTrace, and what we do is we use AI to help doctors make better decisions. And I'm a clinician, and the clinicians in the room will know that we do a lot of things right, but we do remember our mistakes. And if you're a patient that goes into hospital in Europe, the WHO says you have a 1 in 10 chance of being harmed whilst in hospital by the decisions made by the clinicians. 1 in 3 antibiotics are inappropriate, and that inappropriate prescribing is going to cost the world about $100 trillion by 2050, according to the modeling. So we can do better. And can AI help us do better? Well, let's look at what a doctor does. So you go to medical school and you learn. You learn about drugs, you learn about diseases, muscles, bones, how things fit together. But then when you stop, you cannot keep up with the knowledge that is being developed every single day in the papers that are being released. And then you go and train because your knowledge is no good until you learn how to use it. So you go and you get feedback from senior clinicians. But then you go into practice and it's 2 o'clock in the morning and do I need to be closer? It's 2 o'clock in the morning, and did anyone hear anything else? Don't worry. So yeah, it's 2 o'clock in the morning, and you don't have the senior clinician available for you, and they cannot be available to monitor every single decision you make. So then you learn from experience, and I've seen maybe 10,000 patients so far in my career. That's a tennis court. By the time I'm done, it'll be a football stadium's worth. But an AI algorithm can look at millions of patients. It can look at the entire population of a country and learn from each and every one. Can the AI do compassion? Well, maybe, but actually what it can do is it can allow the doctors time to be compassionate, take time to spend with their patients. And ultimately, the AI supports the doctor and it allows them to be wise. And ultimately, it's the final responsibility will always remain with the doctor. So that's our approach, and that's why we think it will work. This is the team. There's 12 of us now. We're a small startup. We started a year ago. And what do? We build decision support tools. So what we do is, when a doctor makes a decision, we give them instant and real-time feedback and say, you prescribed this antibiotic, but actually what might be more appropriate is a different one. And then we give them the ability to interpret that. And we say, this is why the algorithm thinks that this is the right antibiotic, for example. And we allow them to compare themselves against other clinicians to see how they might be performing. And we allow managers or departmental heads to look at an entire population of their hospital and look at what is being done well and what needs to improve to be able to give some better support and feedback. And the process is that we take both structured and unstructured data. So we take blood results, but also the clinical notes, what the clinicians write down, and that's where most of the information is trapped. We de-identify it to make sure that there's nothing private in that information. We process it through our bespoke algorithmic approach, and then we deliver these outputs in real time. And the conclusion is that it works. We've achieved, within a year, human-level performance. We can deliver it in real time. We're very proud of that. And our next step is to validate that in further pilots that will start at the end of this year. Our challenge is to get access to data and do so in a reasonable amount of time, because there's obviously lots of concerns about doing that right. And that's where the ethics comes in. That's what we're talking about today. So we take data privacy very seriously. We treat it as an asset. We monitor how every single bit of data we have. We record why we have it. We trace it. We make sure it's de-identified before we receive it, and then we check again that there's nothing identifiable within it, and we use as little data as we possibly can to do what we want. Then we get external people to test us. Are our data security procedures appropriate in an ongoing way? So we have ISO certification, we have penetration testing, where we ask people to try and break our systems to see if they would break, and we're approaching CE marking by the end of this year. And that, as you will all know, is an ongoing process. So it's not just doesn't end when we release the product, but carries on. Our algorithms are interpretable, so we tell clinicians why we're making that decision, and we also tell them how certain the algorithm is. So sometimes the algorithm will say, listen, I don't know. You're on your own. Okay? We clinically validate. So you'll see these curves a lot. That way is better. That way is worse. You have an AUC. Our AUCs are really good, but what does that really mean? What about the bit that we miss? What is the consequence of even one mistake that we might make? So the way we do it is we have our clinicians validate the output. And then the approach is that this whole approach is human compatible. So our clinicians lead the company. They design how these approaches are, and they integrate it into a normal workflow. So it's compatible with the processes that are already happening.
Umar, can you round off at this moment?
Absolutely. There's lots of frameworks. We're very grateful for the funding that we received and the helpful frameworks. But the last bit I'd like to say is that we can't afford to wait. We must do this right, but this is a problem that will kill 10 million people by 2050. So we need to go and get there fast. Thank you.
Thank you very much, Umar. Then our next case presenter is Professor Paul Verschuren, who is a research professor at the Catalan Institute of Advanced Studies. With a background in psychology, he has pursued artificial intelligence for a long time in a wide variety of settings, leads also a large team in this field, and he will talk in particular about stroke rehabilitation. Paul, the floor is yours.
Okay, thank you, Paul. Good afternoon. It's a pleasure to be here. And what I want to talk about is scalable health technology. Okay? In particular, a system we have developed called the Rehabilitation gaming system, which is based on 15 years of basic science and 5 years of innovation and commercialization. It's supported by EIT Health with a number of partners across Europe. So what's the problem in our case? We want to look at the global burden of neurological disease. This is the most recent update on this by the Neurological Disorders Collaboration Group, published in The Lancet. And what we see that the majority of disability-adjusted life years are accountable to the incidence of stroke. So stroke is one of the main sources both of death, but also of disability in the domain of neurological disease. The scale of this will only increase, as you're all well aware, because of the aging of our population. Right? So this will, again, be 20 to 30% larger by 2030, are the predictions. And we face a number of challenges, both in diagnostics and treatment. Whatever we do in the clinic is very much dependent on human intervention. Okay? On the one hand, of course, always a question of the quality of these interventions, which is one issue of the debate. But one problem that is obvious is this is not scalable in the face of the challenge that we are having to solve. So we are facing this fundamental problem of scaling, and that's where technology has to help us. Intervention is one that is scalable. Right? So what have we built? The traditional trajectory of a patient is after a stroke. You enter the hospital, you might receive occupational therapy or physiotherapy in the inpatient phase. After sometimes 3 or 6 months of outpatient treatment, you're sent home, and that's the end. Overall, patients, the lifetime incidence of this is about 18%, and the lifetime expectancy of such a patient is about 5 years, which I think is dramatically short. We try to change that by teaming the patient up with technology that leads to a soft landing at home and continuous rehabilitation and monitoring by clinical professionals. Right? So in that sense, we want to push the treatment and diagnostics out to the patient in their home environment, offloading, if you want, the pressure on the healthcare system. So far, we have delivered 70,000 therapy sessions across Europe. We treat dozens of patients every day. Over 6,000 hours and 2,500 patients successfully treated. And I can say successfully with confidence because we've published 40 clinical studies. We know this works. But if you now look at what does this mean for the discussion on artificial intelligence, it immediately raises the question, what do we mean with artificial intelligence? Right? So along this whole pipeline that we constructed and that we are deploying at a number of hospitals across Europe, at different phases in this pipeline, you use automation technologies, algorithms, and hardware and data that we can qualify as artificial intelligence in the sense that we start to replace in our automation process cognitive capabilities of humans. So that means classification ability to diagnose, decision-making ability to make decisions on interventions. We're slowly moving to a technology pipeline. And that's the real fundamental challenge in artificial intelligence. Also, what do we mean with artificial intelligence? It's a broad set of solutions that slowly are encroaching on the cognitive autonomy that we usually reserve for ourselves. Now we move that out to cyber-physical systems. The next step in that is that we're going to see very detailed, individual-specific multi-scale modeling. Every brain, every genome, every microbiome, every behavioral set of patterns of individual patients will become captured and modeled in the service of improving individualized healthcare. Right? So this will include past, current, and also future patients. So if we want to have predictive power and intervention power, we must reach this very high level of multi-scale description of every potential patient and every real patient. And that raises a whole bunch of questions because now we have, in order to deliver high-quality healthcare that is scalable to individuals now and in the future, we need large amounts of data of every individual. And this raises numbers of questions, and I just want to highlight a few for you to ponder. But the first one is artificial and human intelligence stupidity. That means, if we have a smart human dealing with stupid artificial intelligence, it's still not going to work, and vice versa. Right? So where is the intelligence really in that system? Also, we should not over-interpret artificial intelligence. We should not try to regulate what we believe in our most fearful dreams is the future of technology. We should look at the reality of it. And it's often not that scary that the robots take over the world. They're very concrete questions. And I believe that we have to really think very carefully about regulation to assure that we can get the data we need to build these scalable healthcare solutions. Because our society cannot support our current healthcare system. If you want, we can say, well, we collect data for law enforcement interventions over the tax office. Maybe we should also collect and store data with the same level of accuracy and reliability and security for our future healthcare systems. And lastly, we could also think about data donation as a civic duty. If you want to live in a society with a sustainable healthcare system, you must be willing to provide your data to that system, but then the system must assure that it deals with it in a responsible way. Thank you very much.
Thank you very much, Paul. I hope that you like these presentations, that this is people who are really doing AI. So AI is for real and also really struggling with some of the questions around that. So that's the kind of a setting that we want to do. Now I would like to ask the panelists to join the stage. Jan-Philippe Beck, the CEO of the EIT Health. Suzanne Demel, of the Managing Director Law and Security of Bitkom. Peter Dabrock, Professor of Theology and the Chair of the German Ethics Council. Hila Azatzoy, the evangelist, I think you might say, for global health activities within ADA Health. And Hans Hofstraat, Vice President for Health Innovation at Philips. Let me see that you find your seats. And then last but not least, Marco Marcella of the European Commission, who will replace Roberto Viola, the Director General, as I said before, to some people, it's dangerous to organize a health conference because someone will fall ill, and unfortunately the Director General fell ill. But we're happy that we have Marco here. The first person to enlighten us will be Jan-Philippe Beck, who is the CEO of EIT Health. He will tell you about EIT Health, but he will also tell you about what I promised, that you will get some results of a very recent survey on AI and ethics. Jan-Philippe, the floor is yours.
Thank you very much, Paul. Good afternoon to everyone. So, my name is Jan-Philippe Beck. I'm the CEO of EIT Health. Happy to be here this afternoon. Fantastic to see so many of you in the room on a Sunday. I would like to give you some insight into EIT Health. First, who we are, what we are doing, and then, as Paul said, tell you a little bit about the survey that we did before we go into the panel. So EIT Health is probably now the largest, or one of the largest public-private partnerships in Europe, focusing on health innovation with the purpose to ultimately develop innovations that can support people to live longer and healthier lives. We are under the umbrella of the European Institute of Innovation and Technology, which is a European Union body. You see a few dots here on the map. This is where our partners cluster. It's 150 organizations around Europe at this point in time. And they are working together in various projects and activities to pursue our aims. Paul and Umar, whom you have seen here on the stage, are also part of this network of, I think, around 1,000 innovators at this point in time that are working in different activities. Now, I think we have brought together a consortium of organizations that you really need from different areas to make health innovation work. And that is, of course, fantastic capabilities from the world of research and education. We've done an analysis of our portfolio now in 2019. I think there's about 100 critical research projects that have been also previously funded in Europe that we build our activities on. There's industry involved with almost 50 key industrial players. If we only look at medtech, 9 of the top 15 medtech players around the globe are part of EIT Health. Healthcare providers are, of course, very important as well. I think the hospitals, the clinics that we have involved in EIT Health are treating about 60 million patients annually. Cities and regions are important. Payers are critical for us as well. And then we have about 500 startups that we supported so far since our birth, so to say, in 2016. Umar is one of them here in the room who is part of our community. Overall, our goals are to strengthen, of course, healthcare systems in Europe and to support their resilience. So we want to bring in innovations forward that can showcase how that can be done. And I think Paul, in his presentation today about the RGS at home, also spoke about how it can support efficiency in how we deliver care. Of course, promoting better health for citizens is the overall and most important mission, but we also want to contribute to a more sustainable and competitive health economy in Europe. We do this overall in three programs that are closely interrelated. So we have what we call the EIT Health Campus that's supporting education and training in health in Europe. And I would like to say that so on the one hand, it's about providing also education to entrepreneurs, but it's also about innovating education in itself and to see how do we need to change our educational systems to be fit for the challenges of the future. We have a portfolio of innovation projects. In those, we try to accelerate new and good solutions to market. Again, I'm referring to the examples already brought, the RGS at Home project, for example, that Paul introduced, is one of those where we see, hey, how can we bring this really to market and implementation? And then business creation is really critical for us. We want to support entrepreneurs with creating and growing their businesses in the health field. Now, why are we discussing AI? Well, of course, it has enormous potential and opportunity, but there are also risks that we will be discussing today. There are technical and, of course, also non-technical barriers when it comes to the introduction of AI-enabled solutions. I think they can be organizational nature, they can be of cultural nature, regulatory, data access. Those are big issues that we are facing. And, of course, we're discussing it because a large number of our activities in EIT Health are dealing with those solutions. Now, you should have somewhere in the room this little report that we produced. And when the Commission put forward the guidelines that Paul already referred to, we said, well, let's actually put them to a test and let's survey innovators, also especially in small organizations and startups all over Europe that we can reach through our network, and let's see what they think about them. Do they actually know about them? And then how are they also applicable to the field of health? And that's exactly what we did. We started this in the summer. This is, I should say, not a broad representative survey, but I think it's a good test for such an important piece of potential legislation. Now, the average size of the organizations that responded has been 6 people, so relatively small, a lot of startups, coming from about 27 countries in Europe overall. It's 82 respondents that we collected. Many of the respondents, 34 out of 58 that responded to this question, actually expect that their solution, once it goes to market, will need regulatory approval. So there is a great awareness that regulatory approval will be necessary. And a number of them also told us that the guidelines might or maybe should also be expanded in scope and also potentially cover other areas that are not covered today, for example, like network infrastructures and so on. Some of the key findings, and I don't want to go into too many details, but because you have also the document here. I think overall there's great awareness and of the relevance of the issues that are addressed in the guidelines. There was little awareness of the guidelines themselves, which I think might also be just due to the timing when they were released, and maybe also the size of this. The organizations of this size do not necessarily always have their eyes on Brussels day and night. But the awareness of the issues was there, and you will see that the majority also says, well, they are highly relevant. The vast majority also says that there is a need for regulatory clarity, so there's a perceived uncertainty around the pathway. And then I found interesting that there are varying views, especially on questions of transparency and traceability, and how that can be applied to a number of solutions maybe brought forward in the health field that might also be meriting more discussion. Now, some learnings and conclusions from this exercise. I think for the European Commission, we would of course think that any regulatory initiative that might be taken needs to take into account what is already happening in the healthcare sector, which is of course already a very populated field. We also believe that it might be useful to detail the guidelines further or populate them with examples specifically from the health field. Now they are very general, and it could be useful to reflect some of the key issues that are relevant for health in particular. And then, as I said before, maybe we should also study particular issues, for example, accountability and transparency when it comes to AI, also maybe when IP or intellectual property is at stake. For us in EIT Health, it definitely shows that we should become active in supporting innovators and startups with dealing with AI, the application of those guidelines. I think there is definitely something around support, providing more support, education, and training to deal with these complex issues to make sure that solutions are fit for market and application. I want to conclude here.
Thank you very much.
Thank you very much, and I'm happy to follow the discussion. Thank you.
So, Jan-Philippe, thank you very much. And we will actually go a bit more into the findings of this survey, but more generally the learning that is happening right in this moment in time on AI and ethics with the panel. The report that Jan-Philippe was referring to is not yet on all your chairs, but if you want to have it, then later on, after the session, come up and register here, leave your name. There are some forms there, and you will be sent the report. And of course, you can find it online as always. So this was about a major health innovation initiative, EIT Health, and a rapid survey that has been done into AI and ethics applied to the field of health and aging innovation. And already gives us some insight, but while we are talking, things are happening. You know, these policymakers seem to be quite keen to start moving ahead and move the agenda of AI in general forward. And so we are happy that we have a policymaker here, Marco Marcella. Marco is the head of the unit in the European Commission's DG Connect, the digital policy DG for e-health, well-being and aging. And he himself has also experience with European legislation. For example, he was the person who negotiated the Web Accessibility Directive through Council and Parliament, so I think he's got a bit of the feeling of how hot it can get when you start to talk about regulation. Marco, we would like to hear a bit more from you about what the European Commission is doing in AI.
Thank you, Paul. Ladies and gentlemen, good afternoon. I'm actually the one who actually took over from Paul, we should say, on the Web Accessibility Directive. He is the originator of the thinking to making sure that every website, public websites, is actually accessible to people with disabilities and beyond. So thank you, Paul. So I will put a little bit of context on what we are doing in commissions in relation to digital health and how do we take it forward on AI. So the first bit will be around the three major instruments that we have. So it is cooperation, it is policy making, and then funding opportunities. Because in a way, so this data-driven innovation is already here. So we are doing it together. And by the way, also in the Commission, we are doing it together. Because I'm coming from the department that is responsible for the digital economy and the digital society, and in health, as in other fields, but specifically in health, we work very closely with our colleagues in DG Santé, that they have the responsibilities on health, and with our colleagues in DG Research for very specific research elements. So the reasons why we are working together is because this is again also on the ethics, a multi-stakeholder approach, where you need to get together the different views of the different stakeholders that have a stake here. So what is the policy framework under which we are operating? Well, it is a policy framework with three axes. So the first one, it is about giving access to data to people and giving them the possibilities to control that data and then decide with whom they want to share and for which purpose. The second, it is about generating new kinds of data. It is working on data that, for instance, we do not have it yet, specifically linked, for instance, the genomics part of the equation. And then third, once you have that data stream defined, you would work on that data to make sure that you deliver innovation. There are two initiatives we have been recently working on when we talk about the data stream, which is the backbone of whatever you're going to do with AI. So first of all, in terms of opening and accessing data, it is very important, in addition to the regulations or the General Data Protection Regulation that regulates and gives the rights to people on accessing their data, to make sure that you can actually access and use this data. And if you look at the healthcare sector today, data is locked in solutions that are not interoperable. So the first thing that we did to create the right underpinnings for researchers to use data is to make sure that you have at least one common understanding on how we transfer data across borders. So we issued a recommendation to the member states on a European electronic record exchange format. No rocket science. It takes into account standards and regulations that are already in place, but it gives a framework under which, using that, you make sure that data can actually flow across borders in a semantic and technological way. The second initiative I want to talk to you about today is the 1 Million Genome Declaration, which is a member state initiative, led initiative, that is a declaration that originated in 2018, signed originally by 13 member states. Now we have 20 member states plus Norway, that they've joined forces with a view to create, by 2022, a cohort of 1 million genomes that are accessible across border. And what is interesting is that the experts that are working in this initiative, they have defined a series of work streams. And of course, the ethical and legal aspects of accessing data across border is one of the top elements of that work stream. So you know the role of AI. I think that we don't need to elaborate too much, but I did put forward an example that comes from Nature Medicines that elaborates on where you can get the benefit. And the benefits span from prevention to diagnosis, treatment, and care. It's a continuum. It's a continuum that includes the administrations, the workflows, the therapeutics, population health management. And if you go around, I mean, every day there is a news on the new technological development, as we heard today, that is actually using AI for a specific treatment. It's certainly one of the fields where you will have most of the results in treating imaging, low-hanging fruits, on digital pathology, but you have applications on dermatology, on cardiology, gastroenterology. And of course, together with research and innovation comes the questions around the guidelines, specifically on the ethical guidelines. I'm sure that you know that there is a document recently adopted by a number of radiologists associations on the guidelines, on the needs for ethical guidelines. So, what is the pitch on artificial intelligence? First, we started with a communication, so a strategy at European level that would highlight what are the challenges and the means to address the evolution of AI in Europe. And there are three elements there. First, that you need to increase the capacity by strengthening investment capacity, our researchers, but also those who are actually going to use it for meaningful purposes, empowering the people to develop and use that technologies, and then, of course, the elements on ethics, a trustworthy society. So this was a balanced approach together with the member states that from one side sees the investment and in the other side says this needs to be trustworthy. So where do you see the challenges there that we will be discussing in a while? Certainly they are with the underlying principles on managing the data. So there are aspects that are really very much related to data sharing or data visiting, or how do you integrate these in clinical workflows and what are the repercussions of that integration in clinical workflows. So from research pilots to real-world settings. And then you see the transparency and accountability, safety and liability, but also the elements of skills. Skills in the medical sphere, skills on those who are the physicians that are going to use this for everyday practices. So here we come to this interesting report, the high-level group on artificial intelligence that issued the ethic guidelines. We welcome the report from the EIT that gives already an insight. So the overall framework starts with 3 components. Whatever we do in developing trustworthy AI has to be lawful, has to be respecting strong ethical principles, and must be robust. Robust in the sense that you know what's going to happen and it is resilient to attack, for instance. So the group came up with 4 basic principles to be respected. So the respect of human autonomy, the prevention of harm, that whatever we do should be fair and should be explicable. So in addition to these 4, let's say, overall principles, you get 7 requirements. 7 requirements that can actually help to fulfill those major principles. The fact, for instance, that there is the human agency and oversight, which means that if I give this AI to a physician, he actually knows what is going to happen with that. And the oversight means that human is in control. So together with the principles, you have an assessment list. And what I wanted to say today is that there is a pilot phase since the issues of these principles that is still running. It will actually end by the 1st of December, and then we will, so for the stakeholders to test these principles and the assessment list of these elements in a specific sector, so in the healthcare sector as well. So we are looking forward. I think that the contributions from EIT goes exactly in that direction, so we will see soon in where we're going. Let me give just 30 seconds on the elements of funding. There are a number of projects supported by the European Commission that are using AI, for instance, in the diagnosis of cancers, in biopsies, in developing clinical trials with specific AI technologies. But we also have calls that are running now, and one of that is to create a large interconnected database of digital images as related initially to the most common form of cancer, which will then be open to the AI researchers to experiment. So this will be an interconnected systems all over Europe that we hope will actually help the developers, as we have seen today, to advance with our understanding of AI. These things cannot be done without ethical principles. And I stop it here.
Okay, thank you very much, Marco. Thank you very much also for your enthusiasm and I think a good overview of what the European Commission is engaging in, although everybody is of course very curious, where the incoming Commission President has said that in the first 100 days of her mandate she wants to come forward with AI legislative action, what that would contain. But we can understand that you cannot give any details on that. But nevertheless, in this panel we do want to discuss in particular on AI and ethics and the legal framing, the framing of rules, legal or not legal, legislative around that. The first person, therefore, that we have that will be able to give us some of the insights is Suzanne Demon. I'm very happy that you're here, Managing Director, Law and Security of Bitkom, and also a member of the Enquête Commission, Artificial Intelligence, Societal Responsibility, Economic, Social Potentials of the German government. And just very recently, a big report came out on suggestions for rules around AI, and I think you must be one of the few persons in Germany that has already had the chance to really go through that report. So, Suzanne, we are keen for your views.
Thank you, Paul. I didn't bring any slides, so I'll just stay here. And maybe we can have a short look on. It was said that when you named the principles, the high-level group gave on developing AI, it said AI should be lawful. Well, that's easily said, maybe not as easily done. And I think the health sector is a quite interesting one to look at when it comes to that, because it is a highly regulated sector already. And I just want to highlight a few points that have to be taken into account, and maybe also a few conflicts of interest that we have in that area. Because health is interesting in so far as we have already heard that the chances of using AI in diagnosis, in treatment, and in all parts of the health sector, they are huge. the efforts we take here can lead to really completely new ways of keeping people healthy. But on the other hand, if we make mistakes here and if the systems we use don't work properly, it is as well quite clear that it will harm people and it will harm our physical health. So when we look, that's the reason why there's already a lot of regulation in place. And for example, we have a new regulation in Europe on medical devices that gives a lot of provisions on general safety and quality aspects. And it will be a challenge because this is a regulation for the first time. We had a directive before with a lot of national organization in the enforcement of it. And so one of the challenges is actually to create new processes and to create the standards we need to use this regulation to give guideline to the companies who develop AI systems for the health sector, and also for the authorities to check them if they live up to the standards we need in order to provide safety and quality. And so this is one important thing, and the other important regulation that we have is the General Data Protection Regulation, which is also fairly new. We had 1 year now, a bit more than a year, to learn to know the new regulation maybe, and. The General Data Protection Regulation gives specific provisions for health data. It says health data is sensitive data, so it has very strict provisions for processing it. And this is the same for the size of your shoes as well as of genetic data. So that you can probably grasp that this is also a huge challenge. When we hear that data availability is one of the most important things that we need to be innovative in this field and to develop new AI systems, then it's quite clear that we have an inherent conflict of providing as many good quality data as possible on the one hand side, and also providing high privacy standards on the other hand side, because these are sensitive data. There's another specifics in the health sector, I think, on ethics. There are many ethics councils already that we don't know, for example, in the automotive sector or somewhere else. So but I think they will have to deal with some new questions like discriminatory possibilities. There will be more individual treatments possible. So I don't know if we have already the proper regulation in these fields already, but I think it's really important when we discuss ethical guidelines and ethics regulation that we first focus on where we are. We don't start from scratch, but we have to look on the regulation we have and see where we have to amend it, or maybe where we have to just adapt it a little.
Thank you very much. So here we got a view from the IT Association, I think, of the German IT companies. Our next speaker will be Professor Peter Dabrock, who is actually the chair of the German Ethics Council. And we're very keen to hear, because you have, of course, a wide scope on ethics, and now the area of AI, and in particular AI applied to health, is starting to heat up. A very recognized person with a theology professor. So we would be very keen to hear your view. You have a few slides, so we should see if the slides can be activated, and we get the clicker to Professor Dabrock to accompany his words. Would you like to start?
Yes. Thank you, Paul. Thank you for having me and present some... It's me.
I'm happy to do it, by the way.
Okay. I can hand over the microphone.
No, only the clicking.
Can continue. That will be surprising. So I'm happy to present some of our not only results but also of our steps of the discussion process of the German Ethics Council on the topic of AI ethics with special regard to healthcare. Generally speaking, we have reached the state of reviews when it comes to AI ethics. And that means that we have reached also the margin utility, not of ethics in AI, but of identifying or having identified the guiding principles when it comes to AI ethics. And we have lists ranging from having identified 70 principles to really smaller lists like having just 5 or 6 principles. And you can go through some of these reviews. I like the review by Floridi and his colleague. He just identified the well-known principles in biomedical ethics, which are respect for autonomy, non-maleficence, beneficence, justice, and as a specific principle, explainability and interpretability in AI. And I think that is sufficient when it comes just to having principles. But the main challenge currently, and this is where the process of the high-level group also copes with, is how to bring these principles into practice, how to translate them, how to implement them. And we all know there very often the devil's into the detail. So this is my first point. And one of the challenges why the devil is into the detail is the fact that on the one hand, especially with regard to big data and specifically with AI, is that all data can become relevant in terms of health, and that means all data may become sensitive data. That means all data are sensitive. And therefore, we have to look for a frame that meets this new challenge in the history of technology. On the other hand, I think we have not only a responsibility for acting in this highly relevant and sensitive field, but we have also a responsibility for refraining from sensible action, as we have heard that we reached also a state where we can move to a more individualized or more precision medicine. And dealing with these two challenges, the German Ethics Council is one of the many ethics boards dealing with AI in healthcare, issued an opinion which dealt with these aforementioned challenges, but focused with special regard on the respect for autonomy principle, and tries to translate it to these era of AI ethics. And we are convinced we have to move from a more input-driven approach to a more output-driven approach. Sorry for interpreting that also the GDPR is more focused on the input of the data process. And we try to look for the outcome, which means in the end we need throughout the entire process of data processing the ability of the individual to keep the controllability on its own data, and this is what we call data sovereignty. And perhaps we have the opportunity to go a little bit more into detail, but we also have technical solutions for implementing this idea of keeping data sovereignty as controllability of the individual when his or her data are and recontextualized. If we follow this line, then we can build what is most important for AI, trustworthy AI, and then we can build the ground for the next step in healthcare. Thank you.
Thank you, Professor Dabrock. That was most interesting as actually also a foundational reflection. Now we will hear two industry views. So we'll first get Hans Hofstraat, Dr. Hans Hofstraat of Philips Research, Vice President in Research, who has a very extensive CV with many involvements that show that he really works with health innovation from the industry perspective, and not only kind of organizing that, but also holding himself lots of innovations and patents for that in this field. He's also a member of the supervisory board of EIT Health. Hans, 5 minutes.
Yeah, thank you very much, Paul. I'm very happy to speak on this very important topic. As a member of the supervisory board, I will be, I would say, representing a broader view than just a Philips view, but as a representative of the large industries in Europe that are taking part. And in principle, artificial intelligence is the message, will help us to move from just big data, that doesn't help too much in itself, to the clinical use of those data. And we have heard there's a huge amount of data that is coming our way, increasingly. We heard just about the 1 million genomics initiative that will overwhelm us with data. Without advanced analytics, we will not be able to use all those data. And then the question is how to use the data. And that is, I think, really aligning with Professor Brock there. It's about the use of AI in this field. People who get a lot of data presented to them and don't know what to do with them. That can be consumers, it can be patients, it can be healthcare providers that can get data on their operations, but how to leverage those data and really to their benefit to reduce, for instance, costs of healthcare and outcomes of healthcare to be improved. And then clinicians that spend more time looking at their screen and at a lot of dashboards and huge amounts of information rather than facing their patients. And by the way, in this example shown here, and I recommend reading the paper by Atul Gawande and some of his books, this is the patient, and here is the healthcare provider, looking at all the data that are presented to him or her, but not being able really to come to a good advice and to show and exert compassion with the patient. And there, the application of advanced analytics and AI will help make more time for that. Artificial intelligence can help across a number of areas. It's in better diagnosis, it's in better delivery of therapy, more precise delivery of therapy, but it's also in, I would say, improving an operational setting where obviously ethics plays less of a role because the data can be totally anonymized. It's about population rather than individual patient. And the opportunities are manifold, and we heard already a couple of them. Finding patterns in complex data, and we as ourselves cannot envisage at the same time more than 5 or 8 parameters or data points. A computer can do much more. But of course then we need to understand what is happening. To create hypotheses, new hypotheses that have to be validated subsequently before they're being used, and then we come to the regulatory activities on that, and then making sure that interventions occur timely, and that you can also leverage, for instance, longitudinal data in a very efficient and transparent way. And then only when you understand the context, when you understand the person, or you understand the healthcare system in which you're operating, or the environment in which you're active, you can use the artificial intelligence and the insights in all the data to its maximum effect. So it's not just about the data and translating that in information, but also you have to take the context into account. And therefore, in terms of leveraging the opportunities of AI, particularly the interface to the user is the crucial part. And therefore, we take a lot of time to what we call co-create, interact with the user, and in the, if you like, the end user. If in the case of a physician or a doctor, it's in the end user, the patient, that also is involved. And you need to take all the stakeholders into account and make sure that the applications are appropriate, that the information is transparent, and that the information can be used in the context of its use, and that the information also is based on data that are representative of this use and therefore can be used. And the challenges you see in this cartoon by a vascular surgeon, Kees Wittens, active in Maastricht. I recommend the book. Unfortunately, it's in Dutch. But the pictures are really illustrative, showing the challenges of the physician in context with his patient. Then on the right, I've pictured the EU guidelines. You heard about them. Actually, important in bringing this into fruition, in bringing this to application, it's, of course, on the AI principles and its ethical use. I already made a couple of comments on that. On the left, I put basically the way that we basically measure and evaluate the things that we're doing in terms of ethical principles, and we heard about them, so I'll not go into too much detail. But it's also very important to exert extreme ethical caution with respect to the data that we're all sharing. And there, the focus in the end, and I fully agree with Peter de Broek, and then I will finish, it's not just about regulating the access to data, but it's rather regulating how it is being used and making sure that the donators of the data trust the appropriate use of the data and see that it's to their advantage. And I'm looking forward to the dialogue subsequently.
Thank you very much, Hans. And as said, we will have one more panelist to speak, and then I will go into a debate with the panel. But in that debate, I would also like to involve you. So think already of points that you would like to make or questions that you have. But first, our last panelist, Hila Azadzoy of the company ADA Health. And perhaps you also have to tell a little bit, though ADA Health is global, not everybody may yet know it, what ADA Health is about. She's a social entrepreneur leading for ADA Health. It's a global health initiative, and also a well-known speaker from fora like TEDx and other places. Hila, the floor is yours.
Do you want to have a look? Great. Thank you very much, Paul, for having us here today to share our perspective about this very important discussion on the governing ethical principles that should underpin every AI, every medical AI specifically. And we're here today to share more, very much a perspective from an implementer that is actually leveraging on a daily basis medical AI to help people all around the world to understand and manage their health. And before we dive into that, what we do, how we do that, it is important to highlight a little bit more the values, why we're doing at the end of the day what we do. And this is all coming back to, and I think that's why everyone is also here gathering at the World Health Summit today, is that health is one of the most important things in life. It is a fundamental prerequisite that allows every individual to reach their full potential, and that's really at the core of why we do what we do, and now going more into that. And while we all know that this is such an important key topic, it is still yet a reality that currently over 4 billion people lack access to even basic primary healthcare services. And that's due to a massive shortage of healthcare workers all around the world, as well as geographical and huge financial barriers. The ones that have access neither necessarily experience efficiency or can be currently any quality guaranteed, with usually either countless of hours spent waiting in the waiting room to then, for example, in resource-constrained settings like in Bangladesh, have an average consultation time of roughly 45 seconds. So in circumstances like these, where access in the first place is highly constrained, and once you have access, misdiagnosis can happen very easily. This is an area where we fundamentally believe that AI and mobile technology can make a huge difference, because traditional models of healthcare delivery will not solve for this global challenge in particular. So at ADA, it is very much our vision that everyone has access to the healthcare they need, no matter where they are. And the way we do this is particularly how we're seeking to contribute to the global goals, and fundamentally believe that UHC by 2030 is only achievable if we leverage and embrace mobile technology and AI. And the way we do this is by bringing what we say the future of personalized healthcare to everyone. This is just a snapshot of one of our solutions, but basically we started way back 8 years ago when AI wasn't a big buzzword, but we looked at the overall cognitive challenge that is there in the space of clinicians trying to identify and detect the right condition, but being confronted with a huge medical knowledge base that is just simply impossible for any human being out there to always detect the right diagnosis at hand. So what we've done is we've built what we call a very sophisticated medical reasoning engine that is combining and linking thousands of symptoms with over thousands of conditions, from communicable to non-communicable to even rare disease, bringing that all together to have a system in place that can compute common and complex symptom constellations within minutes to free up at the end of the day and support clinicians, but also empower individuals in the first place, given this massive shortage and the gap of health workers that we've had. So in 2016, we realized that the system that we've built is not just relevant for clinicians out there, but actually can empower anyone. So we've launched a consumer-facing version of our solution, which you can see here. It's the ADA app. And basically, it starts with, this user, when they have a presenting complaint, inputting their symptoms, their medical history, risk factors, and then our system is providing them with a probability of what the probable cause could be, as well as what next step to take. And currently, we have, upon launching that, it is 8 million users all around the world that are using the app, that have completed over 15 million health assessments, and we're ranked as the best medical app in over 130 countries. In particular, in low and lower middle income countries, we see also huge adoption of the technology that we have, only further mirroring the scarcity of resources in those settings in particular. So 1/3 of our user base is currently in low and lower middle income countries. And in terms of coming back to our vision, increasing access to healthcare for everyone truly means everyone. And there's three aspects that I want to highlight here, how we can do something like that and fulfill this ambition at a global scale. So it requires us to think about three aspects in particular, which is how do we build our technology in the first place, that it's inclusive and accessible. Inclusivity is very much ensured by taking region-specific incidence and prevalence of local context into account. Accessibility, that's one example here. We've just launched ADA in Swahili together with Fundación Botna, making sure that people are actually able to benefit from the technology. And the third one, before coming to an end, that's very important, is making sure that the technology is meaningful in the local context. So how do we link people to actual care? Because the result of our work is very much from supporting individuals, but on a systems level, it is facilitating efficiency without compromising quality, and all the data insights are particularly helpful to also support governments with surveillance and outbreak control, but that requires very much local collaboration, and that's very much what the Global Health Initiative at ADA is focusing on, so that everyone can fulfill their true potential. Thank you very much.
Thank you very much, Hilla. I think we will try to get one more microphone also to the room so that people can pose questions. So let me first pose the first question. When we look at this development around AI and ethics, you know, there are these kind of general guidelines, general schemes that have been issued, and more of them are coming indeed. More ethics councils will have a say about AI in general. But here we are talking about health. So do we understand enough what is specific to health that makes AI and ethics in health perhaps a little bit different from other areas? And I think we heard already a little bit about it. For example, there is this big debate about is it acceptable that algorithms are a black box? Is that acceptable in health? Perhaps in other areas it is, but is that acceptable in health? Can we work with that? Perhaps first, Suzanne, what do you think are some of the specifics on, there's a microphone here, some of the specifics, just 1 or 2 points.
Yes, I think you have to look at what kind of usage do we talk about. For example, when it comes to recognizing patterns in medical data, it could be if you know it works. And it's just an assistance system for doctors. It probably doesn't have to be perfect and completely explainable, because you still have a human in the loop who looks at it, whether it actually makes sense or not, and can still decide. But in other areas where you have an automated decision making, maybe in a medical device where the decision is made, what is the amount of medicine that's given, or things like that, you probably would like to have control and be able to see how the decision has come into place. So I think it's really important always to think that there are so many different techniques and also uses of the technology.
So you have to be nuanced, so to say. But Peter, do you agree? I mean, health is very sensitive, and people are saying sometimes it can go wrong already at the data side.
Yes and no. As I mentioned, that's very often with ethicists. No, the healthcare domain is not specific, as I mentioned earlier, that all data can become relevant in terms of health and in positive and negative way, health relevant exploitation. Yes, since we have, traditionally speaking, a health domain, since we have research in the health domain, we have specific standards there, and these are compared to other data uses best practice standards. So we can learn from the healthcare, and especially from the research in health domain, to put these standards and translate them into other domains. And here I'm convinced we need data of all individuals to go ahead with regard to precision medicine and other applications. And we can only build trust if we have high standards in the field of research, in the field of healthcare delivery mechanisms. And then perhaps it will have a trickle-down effect for other domains.
Yeah. Okay. So perhaps that's interesting, because in a sense you are saying, and I must say, we also found that in the survey that a number of people in health actually seem to know really a lot already about AI and ethics, and they can actually have a message for other areas. But there are some questions. We focus on the topic of what is specific about health. Okay, there, and then one more question there of the person there. So can you do that? Just say briefly, say who you are, and what your question is.
Thanks. My name is Christian Franz. I work for CPC Analytics, a data and policy analysis firm. I very much appreciate the push away from general ethics guidelines. Also now for health, you could demand them. I think that's the wrong approach. I think we are already a step ahead. But what is specific for health, no one so far has looked into toolkits, how to assess a data set or the algorithmic model on whether it's fair, on whether it's explainable, right? We all know our coefficients from regressions. That is understandable.
Okay.
But explain a neural network, and there we all fail, and I think that's the next step.
So we're missing tools. Very good. And then up there, the person who's waving his hand there with the light shirt, can we get the microphone to... you kind of have to fly through the room.
Yes, Boris Azais from MSD. I just wanted to bring back the discussion on a point that Peter Dabrock has made, and I think it's really important. So all data is sensitive. That was really shown years ago already by this anecdote of an American family learning that their teenage girl was pregnant because they started receiving coupons for diapers and milk formula. And that was a long time ago. And so, in a sense, I think that's what you said. But since it wasn't covered by the other speakers, I think this is really critical. All the regulatory framework for data privacy is pretty much based on the name. If you have the name in a database, then you have a lot of regulation applies to you. What we see today with online merchants and search engines, etc., is that basically you don't need the name to know who you are. And so, how do we design the data privacy framework while we have tools that are so sensitive that they can pretty much spot you?
Excellent.
And my last point is to Susan's point was that there's probably a different approach in what we've been talking about today between information curation, help, decision help, or support or tools to help to reach a clinical decision, and also AI use for prevention. And that's a completely different game.
Okay, thank you. Let's stop at that. Hans, I want to go to you. I mean, this issue about perhaps we indeed don't have enough tools to assess either the quality of the data, but also the quality of the algorithms and what happens with that and the right tuning of those to, in the sense that you cannot start de-anonymizing and going back to, let's say, actually a breach of privacy.
Thank you. Yeah, so I can give many answers actually, because it depends, and it depends on the particular application that we're after. I think what is very important, particularly with AI, is really to show where the results are coming from, and it's possible to trace that back and to make a relation and to make it understandable. I think maybe it's not always necessary from a regulatory point of view to some extent, but certainly it's necessary to do that to gain the trust of the user. And the trust of the user is an essential thing to implement these applications in clinical practice. The other thing is that it's really important that the data are representative of the use case as well. So there's many things that you can do to ensure that. Actually, was in another panel the day before yesterday. I think too many panels. And there was somebody else who was pointing out, and that was related to drug discovery, actually, that most clinical trials are done on males between 20 and 45, healthy males, and then people are developing algorithms on the basis of that, not taking into account that I guess a little bit more than 50% of mankind is female, and there's also many more people, including myself, older than 45, that also are interested in having the, I would say, the luxury of using this kind of interpretation. And so I think there's many things already that can be done to make sure that the data are representative, that they're robust. Big demands also on companies, of course, to make sure that data are accessible and interoperable, and the fair data principles, and to also ensure that there is a trust from that side as well.
So that sounds there's some really practical work that can happen. I think we can go on this point, but given that time is fairly limited, I actually want to pose a second and perhaps rather challenging question to this panel and also to you. So people are talking now about introducing AI regulation. And some people are saying, oh, that's far too early, you know, because AI is still very much developing. We don't know what we're doing. Other people are saying, well, look at what's happened in, for example, the social platforms. Things were just left going, and we got into terrible situations that have to do with things that, for example, Zuboff calls surveillance capitalism. So it can also go wrong if you let things just go like that. And by the way, some people might say, I think a number of you are saying that here, we already know a lot about AI and ethics when it is about health. So perhaps it is the right time to regulate. So is it too early, too late, or the right time for a regulatory approach? Peter, your view.
In some terms too late, in some terms too early, and the best time for good regulation. Ha! This is where we all agree on. But I think currently, also with regard to the big report published in Germany a few days ago, I would say we have to find or look for the happy medium between, on the one hand, keep the individual affected by AI in a position of, generally speaking, controllability, and on the other hand, look for still openness to innovation. And openness to innovation means, on the one hand, in terms of the economy, and on the other hand, in terms of the regulation. And I think the most challenging point is, and you guy there picked it up, is the question of algorithm as black box. Here we have the alternatives. On the one hand, to from scratch narrow each kind of innovation by extreme standards and narrow steps of regulation, or I'm more in favor of to look at the possible outcome and set standards, for example, of liability for the individual affected. And if we run in this direction, I think we find the balance between innovation and regulation.
Perhaps, yeah. So you are saying for certain aspects it might actually be the right time, but you have to be pretty careful. But in particular, when you look at things like liability, for example, you might want to move forward. And health and liability is, of course, a super important thing. Suzanne, we already more or less heard your view, but do you think that sounds like a reasonable proposition?
Well, yes, I definitely think it's too early to draw a horizontal or to put up a horizontal regime in all aspects, because it's easier to look at certain sectors where you create higher risks from the context in which you use these systems. And it's the same like with data. We have all data can be sensitive. It depends on the context it is used in and it's put together. So it's the same with algorithms and automated decision making. The same thing can be completely harmless in one context, and it could be really risky in another. And so I think we have to be really careful not to overdo things concerning regulation, but to concentrate on those points where it is necessary.
Good. Yeah, so this is a difficult point, and I don't want to get here into the ideological debate of regulation versus innovation, because that's often not coming with many arguments, but it's just a statement. Let's see, please, a nuanced view. Here's someone who's got a question about the timing on regulation.
Hi, I'm Ocean Bell from Ruby Hall Clinic in Pune, India. And my question is mainly directed to actually Ms. Azad Zoe. As a doctor who deals with a lot of patients who have their own idea of the diseases they have. They get these ideas from apps and the internet, of course. So is there an algorithm that stores the things that people are searching for to perhaps classify them as hypochondriacs? Is there anything in place? Like, I'm asking that because it's a really interesting thing, because obviously we can't deal with all the patients in one day. So it's good, but at the same time, is like that possible? Yeah. Would be my question.
Hilla, please answer that question, but also bring it in the direction of, is it time to start talking about responsible algorithms, kind of some classification of that?
Sure. Yeah, I think what I can directly to the aspect that you brought up, what we see, I think, and typically, and as your experience as a doctor, when you have people Googling their symptoms, and over 80%, I think, in the US are always doing that before they seek care, that indeed is something, an area, you get unstructured information. It's not really specific. It's not personalized to the individual. So definitely there, I can understand how that can affect the interaction between the clinician and the patient, and probably result in frustration on both ends. I think how we approach that is very much almost mirroring a little bit, mirroring the process of how a doctor is collecting patient history in the first place. So we're mirroring that with our technology so that, and that's coming back to the point of explainability, so that we can show transparently to the user, this is why we think you not have XYZ, but we think there's a probability for XYZ conditions, and this is the positive evidence, this is the negative evidence. And that means, because it's a white box approach at the end of the day, that the clinician can understand it and derive value out of it, because, with diagnostic accuracy and at the end of the day, the decision power is with the clinician, can override it, but having that information at hand is something where we see a lot of potential to overcome that. In terms of regulations and the questions, is it the right time, is it too late, too early? From our perspective, and in that specific sector that we're in, I'd say it's the exact right time to get started with this. And we've been involved in some work on a global level together with WHO and ITU to come up and start developing a standardized benchmarking framework, because at the end of the day, whether it's for users or it's the provider side, you need to have some benchmarking systems in place to allow to assure quality in the first place. And I think for that point, and in that specific sector that we're in, it's the right time to come up with a global framework to be able to assess industry-wide all the companies, all the solutions, and give the transparency to the user at the end.
Yeah, interesting. Marco, you are a policymaker. What is your view? Of course, the timing is right when the Commission does something. We understand that. That's always like that.
You know that.
Perhaps you clarify a little bit of the thinking. How does a body like the European Commission actually get to a proposal, a legislative proposal? What is it that they need for it, and what is it that they can get as input from this community?
Yeah, so it is the right time for reflection, as you say. And the legislative process at the European Commission is a very open and transparent, where you get feedback from the audiences, you get feedback from the stakeholders, and you pass these discussions to the member states and to the European Parliament for reflections on what they are the items on which you want to intervene and why, with a solid understanding on the impact assessment of that particular regulation. So I very much like the approach of saying there are already elements where if you take data and you take the algorithms, you have already pieces which are already regulating the evolutions, specifically in healthcare. I would add to the ones you mentioned, the NIS Directive, which is about making sure that the information systems that do contain data, they are themselves protected, and there is a clear thoughts on how to intervene and what to do in case of breaches or problems or attacks. Yeah. So so it's clearly that you would intervene where it is necessary on the basis of this analysis, so the feedback from the constituencies and an assessment of where it makes sense to intervene with a specific regulation, making sure that this does not hamper innovation.
So anyone who has a view actually has an opportunity also to submit that to the European Commission.
Yes, in terms of feedbacks, yes. Yeah. I mean,
okay, let's. There is a person there who has a a question to raise, but let me first raise a general question to you. So while the microphone, okay, good. Then we have two questions, but these two persons. Let me sit down for a minute. Let me first ask a question to you in general. So who thinks it is too early for regulation? Raise your hand. Who thinks it's too late to start regulating AI? Who thinks it's the right timing? Oh, wow. I think that's clear. But that's clear, that doesn't mean the end of the debate. So first the question there, the person who just stood up, yeah.
Hello, my name is Bukumi Adjose. I'm a medical student from the University of Debrecen. I want to ask Ms. Hiller a question. You spoke about using the artificial intelligence in Africa and in underdeveloped countries. I wanted to ask, how would the fact that they are not really, in some of those underdeveloped areas, they don't have access to electricity and maybe iPhones or smartphones, how would that play a part in you giving them AI? And also, what's the time frame for this to be implemented?
Hiller?
Yeah. Absolutely, and very important question. So currently what we see is the existing user base is already growing in sub-Saharan Africa. So it's roughly between 300 and 400,000 people across different countries. So there's some usage, but the aspect of connectivity is critical. So currently it is very much smartphone self-selection, so the ones that have access to connectivity and smartphones. What we're looking to do to further increase the impact and the scale is, on the one hand, looking at potentially upskilling semi-skilled health workers with our technology. So if you reach at community level health workers that are out in communities and that have some form of connectivity and a smartphone, you can reach more semi-rural populations. I think in entire rural populations where connectivity has not catched up yet, it is difficult, but we do feel in urban and semi-urban areas is where we can get started. And with the projections of smartphone penetration doubling and being on the rise, we feel like in 5 to 10 years from now, that is going to be also the reality that everyone will have access to mobile technology.
No doubt that health for all, also in the context of AI, is going to be a key principle. That person who was raising his hand there in the grey shirt, yeah.
Hi, my name is Mujahid. I'm from the Hertie School. I wanted to ask about the equity implications of AI solutions, not in terms of the people who are using it, but in terms of the people who develop these solutions. You can't expect a group of men sitting in America to develop maternity care services for women in Africa.
Yeah.
So what do you think are the equity implications of these things? And is there a regulatory recommendation or practices to have a more diverse body developing AI solutions?
Yeah. Hans, how do you in practice go about? Because you actually also raised the point that this may be a risk, the bias.
It's about the appropriateness of the data and doing that in context. And I would say that certainly not all companies are only developing these applications in North America or in Europe. For instance, many of the applications we develop are developed in our research center in Bangalore or in Nairobi, where it's, of course, essential to have the appropriate data, because otherwise you cannot develop an AI application. So these applications are developed locally in the local context with data coming from, I would say, representative population. So there's no way that it's possible to develop these algorithms in Eindhoven in the Netherlands or in somewhere in Silicon Valley exclusively. So we really need to reach out. We need to do that together with local clinicians, with local academic institutes, and basically getting the appropriate data to develop the appropriate algorithms that are representative.
But perhaps you also need to have benchmarks for that, and best practices for that. Let's take a last question here, lady here in front. Then I unfortunately need to start rounding off this session.
Thank you. Brigitte Bürlin, I made a foundation for family carers. So my question is, to whom belong the data? For they are worth much money. And on one hand, like Ada, it's very good for people to be treated well and to get knowledge of their diseases, but on the other hand, you collect data. What do you do with the data? Are they are money worth? So perhaps the patients will be get their money.
Yeah. So
get we money for our data?
To whom belong the data? And this is a more general question, but for health in particular, sensitive. So you have, I think, two possibilities. They belong to the patient, or they belong not fully to the patient. So let's do a simple raise of hands. The panel. So who raises the hand and says the data belong to the patient?
Well, first of all, it depends on what data we
I know. You want to give a more nuanced answer. And I think that's the crux of the matter, because this is a field where you need to have nuanced answers. There is not a simple answer, nowhere. It depends. Peter? You want
to I strongly warn against one answer fits all problems response. Yuval Noah Harari said the question of who owns the data is one of the most important questions of the 21st century. So if we look for a simple solution in this case, we really run in not only the false direction, but devastating consequences. So I strongly warn against a simple answer.
So I think in many fields you see that, especially as this ethical value dimension gets involved, the answers aren't going to be so simple. And we need to have a debate. We need to have a global debate. And certainly in Europe also the debate is strong and lively. Jean-Philippe, for you perhaps the word about what is the contribution of the EIT Health in Europe and what can it contribute globally?
Well, I think the one contribution that we can make is to be close to the community of innovators, and I think that's something that we tried already ahead of this panel to also survey and see what do people think in the field, where also issues, and I think what we can contribute is to bring that back, bring views back, and try to consolidate them. On the question of regulation, I mean, one thing that I take away from the exercise is that there is a lot of unclarity also, especially for smaller organizations around the regulatory pathway. And I would also think that there is the right time maybe to take some key steps forward, but to do that in a European or if not global approach, because I think especially, again, also a lot of smaller but also larger companies also suffer from fragmentation. In Europe, there's a lot of diversity of rules and so on. And I believe if we really want to capitalize on the potential of the technology, we should not shy away from a European, if not then more global approach. And maybe we can contribute with views from the field to that.
Thank you very much. For the grand masters of this conference are signaling to me that it is about time that we wrap up this session. Unfortunately, because many of you have been raising their hand, and I think that's quite a good reflection of that. This is a real, true, serious debate where we as a health community, as a health innovation community, have something to contribute, not only in Europe, globally, very much so. I said that you can get this report, register your name over there. You have ideas. I wanted to ask the panel, but we don't have time for that anymore. What is your message? What has to be happening in AI and ethics? Send your message. What has to happen in AI and ethics right now to the European Commission, to Marco, so that they have got a good input of your views. And I would like to have a big hand from you for the panel and for yourself for contributing.